Hello, my name is Dr. Shanda Blackmon. Welcome to the Baylor College of Medicine Lung Institute podcast series. We're here to communicate with all of our care providers, our learners, and our community, as well as patients, about how to improve lung health, how to educate you and all of the people around you about ways to prevent lung disease, treat lung disease, and maintain lung health. Hello, my name is Dr. Shanda Blackmon, and welcome to the Baylor College of Medicine Lung Institute On Air podcast. We're so excited about today's episode. I've been trying to get him in for quite a bit of time. Today we have Dr. Ivan Rosas. He is the section chief and lead for the Pulmonary Critical Care and Sleep Division, and he is one of our best leading investigators in the area of lung health, prevention, and intervention for lung disease. He runs the Advanced Lung Disease Clinic, and he also leads some of the most exciting research that we're doing in the area of lung. Welcome.
Hi, Shanda. It's great to be here.
Yeah, love having you here. So let's talk a little bit about the diseases that you treat. What is the Advanced Lung Disease Clinic, and why is it so important and critical to patients with lung disease?
Great. Well, the simple way to think about this is there are common disorders that our pulmonary specialists are very well trained, and because they see these patients on a regular basis, they can very effectively diagnose and treat. So an example of this is asthma, right? A very common condition in which there's extraordinary progress in understanding the pathogenesis, and therefore there are very effective treatments. There are refractory forms of asthma, and which is very complicated to treat, and so we do have a specialized clinic run by Dr. Hanania, who you spoke with recently. But for the most part, I think that asthma management is very well established. This is in contrast to other conditions that are rare, less common. And so one example of this is the area that I specialize in, which is pulmonary fibrosis. A lot of people actually confuse pulmonary fibrosis with another uncommon disease called cystic fibrosis, and I'll let Dr. Bartow in a future visit talk to you about that condition. But we're talking about pulmonary fibrosis, which is presents mostly in individuals above the age of 50 or 60. I don't like to see older individuals because I'm already in that range, and so I just call them individuals that are in their later stage in life.
Okay.
And so the disease is very uncommon when it presents before this age. And if we, in general, look at a very known form of fibrosis called idiopathic pulmonary fibrosis, the estimate is that somewhere between 150 to 200,000 folks in the United States are affected by this condition.
Okay.
The definition of a rare disease by the National Institutes of Health is a condition in which there is less than 200,000 individuals. So it's just on the borderline.
Right. But even though only a few individuals are affected, it's a severe disease and sometimes can be life-limiting, right?
Yeah. It's a podcast, so I'm going to tell you a story.
Okay.
When I was actually training, or when I was doing my internal medicine training, one of my goals was actually to be an intensivist. I really enjoyed the ability to intervene quickly and see the effects of an intervention, which is what you see in the intensive care unit. But 2 months into my training, into my fellowship, I had the opportunity to care for a very young individual. She was a 35-year-old African-American female who had suddenly developed a very aggressive form of fibrosis. Unfortunately, within 2 months, she had progressed so rapidly that she had to be evaluated for a lung transplant, and unfortunately did not have enough time because at that time we didn't have the present lung allocation score, and she unfortunately died from this form of fibrosis. Now, this is a very unique case. It's called acute interstitial pneumonia, and it's a rapidly progressive form of fibrosis. But I think you're right about your comment that idiopathic pulmonary fibrosis, as the prototypical condition, is a condition that is relentless in its progression. And on average, an individual who is diagnosed with this disease within 5 to 8 years will be confronted either with an opportunity to have a lung transplant to increase survival, or unfortunately will die from this disease.
Okay.
And when I first encountered that, it was a surprise to me that people could die so quickly from a condition like pulmonary fibrosis.
Right. And I think most of the people that I know that have been diagnosed with pulmonary fibrosis are surprised by the diagnosis. They aren't really sure how they got it. They weren't really sure why they weren't diagnosed earlier, and they worry, is this something that my family members could have? And then some of the people that get diagnosed don't always understand how severe it is, and they have no idea that they're going down the road heading for a transplant or hospice, right? Like, that's not what people always think about when they get first diagnosed with a lung disease.
Yeah, there's so much in that comment that you just made. So let's just kind of break it up into little pieces.
Okay.
People who are affected with pulmonary fibrosis talk about this journey of being diagnosed. Right. And so it's not straightforward, again, because it's a rare condition. So patients talk about the journey of diagnosis of pulmonary fibrosis. The diagnosis usually takes some time to establish, in part because it's not a common disease. And so not everybody's thinking about fibrosis. People are thinking about COPD.
Right.
But pulmonary fibrosis, again, because of its lower frequency, is not at the first diagnosis people think about. And so on average, I'd say that individuals who are diagnosed with this disease spend maybe 2 years or 3 years getting diagnosed with this condition. The symptoms are mild and indolent, and so there's no urgency to actually make the assessment. At least that's kind of the clinical scenario. And ultimately, after seeing 1, 2, maybe 3 physicians, you'll reach a diagnosis of pulmonary fibrosis. So it is challenging.
And would you call it a diagnosis of exclusion, where all the common things have to be ruled out, extensive testing? If you had the right person doing the diagnosis, do you think they could be diagnosed earlier, or is it just necessary that they have to go this pathway?
Clearly, it's not necessary. And clearly, we have to do much better of identifying individuals at risk of developing pulmonary fibrosis, which ties nicely in with this concept of early detection.
Right.
So let's talk about that. Early detection is a concept that has been around for many decades, maybe 70, 80 years with cardiovascular disease, and maybe another 50, 60 years or maybe more with conditions like cancer. And when I was training, this is something that came to mind, is why aren't we actually trying to detect pulmonary fibrosis at an early stage? And my mentors at the time claimed 2 things. One, it's so uncommon that how do you actually generate a strategy to detect early? And second, at the time, this was more than 20 years ago, there was no treatment. So why are you detecting early a deadly condition in which you can do nothing about? I reasoned, well, I think there should be individuals at risk. We just need to identify those. And then it's certain that because of all the research that was going on at the bench and in clinical research, we would at some point be able to identify therapeutics. Lo and behold, not surprising, these 2 things have happened. We have 2 drugs that are now approved for fibrosis, and there's a third that's coming. Hopefully early next year, the FDA will approve nerandomilast, which is the last class of medications that's been proven to be effective in fibrosis. And in terms of risk groups, there is one clear risk group. It was very evident that there were clusters of individuals who actually developed pulmonary fibrosis, and it's called familial pulmonary fibrosis. But we thought and still believe that this is uncommon. But more recently, our research group and others have shown that first-degree relatives of a single individual who have pulmonary fibrosis may be at risk as well. So let's just say that genetics of pulmonary fibrosis suggest that we could identify a subset of patients who are at risk of developing fibrosis, and potentially we could screen these individuals.
That's fascinating. So we did a podcast with Richard Gibbs, who sequenced the human genome. And I think you and Richard are working together to try to look at the genetics of pulmonary fibrosis and identify those first-degree family relatives. And you have a clinical trial that's open right now, right?
That is correct. So Richard actually runs the Genome Center at Baylor, and we are working or collaborating in an NIH grant in which they are doing the sequencing for both patients who are enrolled at Baylor and at Brigham Women's Hospital. Okay. So this NIH-funded study has been ongoing for now 10 years and aims to identify at-risk individuals And we think that we will be able to use some of the known genetic variants that are associated with pulmonary fibrosis to predict those who may actually go on to develop the disease, or even detect these individuals just by being part of a family affected with pulmonary fibrosis with routine tests like CT scan and pulmonary function tests. And to the point of a clinical trial, although this is an observational study, the work that we've done in research over the last 20 years has ultimately led the pharmaceutical industry to get interested in this quote-unquote phenotype, detecting a disease in an early stage. An individual who's going to have progressive fibrosis may be a great target for treatment, and obviously will increase the number of patients who can be treated with antifibrotics, which is the class of medications that treats fibrosis.
So you said we have 2 drugs, 1 drug on the way, and these antifibrotic treatment drugs or treatment strategies might be able to mitigate the development of pulmonary fibrosis. But there's another advantage, and I care passionately about this because I take care of a lot of people with lung cancer. I think there are individuals that if they knew they were going to develop lung cancer might behave differently, and that knowledge might affect how they behave. So if you identify a family cluster of pulmonary fibrotic patients, do you think it might affect their behavior? Like perhaps they would be the least likely people to smoke, right? You might recommend things that they would avoid to keep from accelerating the disease.
That's a great question. And as a matter of fact, when we initially proposed this study a decade ago, we had concerns about providing information to individuals who don't have symptoms and don't really know they have the disease, because you could probably identify 2 extremes. Those individuals that want to know that they're at risk so they could actually take preventive measures, and other individuals who probably just don't want to know because they don't want the burden of having to know this, and maybe they don't want to modify these behaviors. So I'm not a behavioral specialist, but I think in the end, part of what we're going to have to do is determine what individuals will actually benefit from this information. So part of the grant is focusing on looking at the reactions. And so we have a genetic counselor that actually provides the results of genetic testing. And we're seeing if there is potentially some harm in providing individuals who actually have a great quality of life, they're completely asymptomatic and normal, with information that could create concerns about their future. I think overall, my experience with families affected with pulmonary fibrosis is that families and family members want to know. And they want to know for the reason that you've pointed out, because they want to actually take actions to try to prevent the development of disease, or if they're going to develop the disease, be empowered to do the right thing in terms of their management.
Or incentivized at the minimum, right?
Correct.
And now that you have drugs, it makes a lot more sense. I think
Correct.
You think of Alzheimer's testing, and a lot of people don't want to know if they're at risk for developing Alzheimer's because they don't think that there are a lot of really good drugs. But we do know that getting enough sleep, working on memory, looking at nutrition, and some things might make a little bit of a difference in the progression of that disease. But when you have a drug that's out that does look like it helps, then you start really thinking about interest from both sides, pharma and patients.
Correct.
Great.
I have to say that we are far from having the quote-unquote magic remedy for pulmonary fibrosis, but I think there's a lot of progress in understanding the mechanisms of disease, and there is, because of that, a lot of opportunities to develop drugs that will be more effective and have lower side effect profiles, which I think is one of our limitations right now. I think you were pointing out that these medications may help. How do they help? They slow the progression of the disease, but we really don't have a medication to date that actually stops the disease where it is, or maybe actually provides the lung with an opportunity to regenerate or to actually repair from the damage that it has. And so there's still a lot of work we need to do.
Yeah, well, of course, then it would be a dead-end street for your research if you didn't have future opportunities. So.
Well, I'd love to be out of business if we could.
We all want to work ourselves out of business.
Exactly.
So if I think about your practice, the majority of your practice is pulmonary fibrosis, but you treat other diseases besides that. And I'm sure this podcast doesn't give us enough time to talk about everything. But one of the things that I'm always interested in as a surgeon, sometimes I see someone with like Birt-Hogg-Dubé syndrome. And I met a patient a couple weeks ago who has that. And she's an advocate nationally and loves to talk about it. So we've talked about on the podcast, not just featuring specialists who treat the disease, but featuring patients who suffer from the disease and are advocates nationally for others who suffer and can talk about what it's like to have the disease. Talk to me a little bit about Birt-Hogg-Dubé and how these other orphan diseases that you've picked up that are even more rare than pulmonary fibrosis. Or
Thank you. I mean, that's a great question. I'm going to go back to the beginning of the podcast when you talked about what does the Advanced Lung Disease Programs.
Yeah.
And so, IPF is a good example of a rare disease in which multidisciplinary care, you and I, have different expertise, but when we work together, we can provide patients with medical care and transplant, for example.
Right.
But this multidisciplinary approach, which has been validated in many diseases, is very relevant to what we call rare diseases. Mm-hmm. And so I've already defined what a rare disease is, but there are really uncommon disorders that go beyond the definition of the NIH, and Birt-Hogg-Dubé syndrome is a good example. So Birt-Hogg-Dubé syndrome is a syndrome that affects individuals in creating bullous lesions in the lung. It's thought to be, it's strongly associated with a mutation in the folliculin gene, and it's thought that this mutation actually leads to structural changes in the lung that leads them to develop these bullous changes. Unfortunately, although we know a gene that's responsible for it, we don't really understand the mechanism by which the gene actually causes the disease. Moreover, we don't actually have, other than surgical interventions, we don't have a treatment, and certainly we don't have a cure for Birt-Hogg-Dubé syndrome.
But maybe with the CRISPR technology and gene editing, once we identify that exact area, we do have some new technology.
I think you bring up an important point, which a lot of these rare diseases are actually associated with genetic mutations.
Right.
A little bit more common disorder, but actually related in the population because this is considered a bullous disease, and bullous disease may be related pathogenically to cystic disease. And so you have this other disease called lymphangioliomyomatosis.
Oh, no thoracic surgeon. You can never say lymphangioliomyomatosis or LAM in front of a thoracic surgeon without having the Clint Eastwood eye twitch, right?
That's right.
We all are traumatized by the patients that we've cared for that have that disease. It is probably one of the most frustrating diseases to care for.
That's correct. But one of the things that's common, and goes back to your comment to these disorders, is that these disorders have been found to be associated with genetic abnormalities, like loss of heterozygosity in the case of LAM. So back to your comment of actually enabling cures through modifying genetic mutations. Mm-hmm. I think that this is a real exciting time for this. So there's a combination of the ability to find a genetic mutation and then model this through iPSCs. So there's a form of stem cells that we can actually modify to be able to generate some of these mutations and see what the impact is on the development of the disease. But at the same time, we can actually implement CRISPR technology in the laboratory setting to try to revert these abnormalities and see if we can change the effect of the genetic mutation.
Now, just for the public, the iPSCs are intrapulmonary stem cells, right?
No, so it's when stem cell research was being developed, one of the limitation is access to stem cells because for many reasons, including regulatory reasons, we don't have broad access to fetal stem cells.
Right.
And so a technology was developed to actually use transcriptional regulators to induce pluripotent stem cells.
Right.
So iPSC, it comes from that. It's basically our ability to induce...
To make pluripotent stem cells.
Correct.
A little bit different than exosomes. So exosomal therapy is sort of bypassing that whole stem cell process, and there are even exosomes now that can be inhaled and used for treatment.
Yeah, I think that the area of regeneration, which I think is what we're heading to, includes different tools. And so I think you're right. One of the tools, and one of the tools that actually is pretty attractive for the treatment of pulmonary fibrosis could be the use of stem cells. But cells have ways to communicate with their environment. And so one of the ways they communicate is with microvesicles, and kind of a group of these microvesicles are exosomes. exosomes contain cytokines. They contain different proteins that may be non-structural proteins or sometimes structural proteins, but they also contain microRNAs. So think about these microvesicles or these exosomes as being carriers of information. And this information may be, the target may be a proximal cell, so crosstalk between cells that are adjacent to each other, or it may be through the circulation to other remote cells. So we are starting to understand how exosomes actually may modulate other cell types, and it's possible that either through proteins or through mRNAs, a cell that's affected by a condition or a cell that's trying to help an organ that's affected by a condition may benefit from exosome therapy. And we're seeing it in cosmetics, and we're seeing it in more serious conditions that exosomes may actually have a beneficial effect.
Yeah, so we've talked a little bit about rare diseases like Birt-Hogg-Dubé, lymphangioliomyomatosis, pulmonary fibrosis. The Advanced Lung Disease Clinic sees them all, sees them in a multidisciplinary fashion, and if there's progression of disease, is prepared to link them immediately with a lung transplant team. Talk a little bit about with me how we get patients into the ALD clinic versus the lung transplant clinic. Like, what are the criteria? How do people know if they're a candidate to come into one of those clinics?
Yeah, thanks for that question. I think the concept, and the name has some deficiencies, but I think the concept of the Advanced Lung Disease Clinic is patient-centered care. So what does that mean? It means that the clinicians and the staff that actually work with clinicians are focusing on the patient experience rather than the logistics of how they provide care. And so in a patient-centered experience, you'd have a space in which patients would benefit from just the geographical proximity of clinicians that can contribute to your care, to their care. So for example, I could be in clinic seeing a patient that needed a surgical intervention, and you would be next door, and I'd just be able to come out with the information and show you images and have a quick discussion about how care for this patient. But I go to the left to the other side of the clinic, and I could talk with a pulmonary hypertension specialist, because pulmonary hypertension is a common disorder that is associated with chronic lung disease. Or I could just go across the hallway and talk with the research coordinator who's sitting there waiting to enroll patients into registries or into clinical trials. And so what you want to think about is a patient experience in which the different components of care are present in the same space, the communication is efficient, and therefore the care is both expedited and available through a continuum of their condition. So I start with early detection of a disease that I know is going to be progressive, and I get access to interventions that otherwise I wouldn't have had because the condition was not diagnosed. I get genetic testing so I can actually see if my family is potentially at risk for developing this disease, and I have access to experimental therapy in the same space. But as the disease progresses, I'm going to need some cardiovascular evaluations, or I'm going to need surgical interventions, or I'm going to need physical therapy or pulmonary rehab. In the ideal multidisciplinary setting, the patient is getting all that care. This is why many places like the Mayo Clinic, where you came from, or Cleveland Clinic are so successful, because a lot of their focus is on making sure that the patient gets this expedited and cutting-edge care.
Yeah, and I think when I think of the Baylor College of Medicine Lung Institute, there's a lot of crosstalk between the disciplines. There's a lot of crosstalk between the surgeons and the pulmonary interventionalists. Today, I'm going to spend a half a day with Dr. Babith Mankitty. He's doing an endoscopy and putting a stent in on a patient of mine. And there's so much communication back and forth that it becomes almost fluid, like we're in the same department or division, rather than having these silos that you see in private practice or in other non-traditional practices. In our lung institute, what I see is a lot of side-by-side practice, a lot of collaboration, and a lot of communication. So when a patient with Birt-Hogg-Dubé comes into your clinic and I see them, you've been educating me about this. I've been reading about this. I've been taking care of these types of patients for 20 years. It's not the first time I've seen a patient with a rare genetic disease. I think patients want to go to a place that puts them first, where they hold court in that clinic, but they're also cared for by people who are familiar with their rare disease and don't do the wrong thing or do harm.
I completely agree. I think one of the things that clinicians should do more frequently than we do right now is to try to put ourselves in the place of the patient. Like, with all the knowledge that we have, if we were confronted with a condition, what would be the perfect setting to get your care? And I think it would be exactly what you're talking about. Not necessarily the first person that I see will know everything, but the person that I see has the ability to make those connections that will make the care optimal. And that's really the premise of the Lung Institute. And definitely on a more practical level, that's the definition of the Advanced Lung Disease Clinic. So I saw a patient last week who I'd been seeing now for almost a year and a half. Very complex case. Definitely a patient who has fibrosis. But, 18 months into the care, I challenged myself. Like, okay, I've been seeing this patient for 18 months. I think I know what I'm doing, but am I doing the right thing? And so I looked at the case more carefully, and I decided to get a second opinion. I actually requested the second opinion because there were features about this disease, this rare condition I was treating in this individual, that actually reminded me of a condition called bronchiectasis. So airway distortion can be associated with fibrosis because fibrosis kind of tugs or pulls on the airway. Right. But bronchiectasis can be primary and a consequence of neutrophilic inflammation. And there's some progress right now in this area, new therapies. Mm-hmm. So I wondered, as the patient was telling me, making some comments about sputum production and some of the symptoms, I wondered if the disease had an element of bronchiectasis that was not related to mechanical traction, but more related to primary airway involvement. So I have an expert in bronchiectasis, and so I called the expert up and said, look, I have this very interesting case, look at the images, and we had a 5-minute discussion, and the expert said, of course, I should see this patient, and let me provide you with some information and feedback on how we can better care for the patient.
So we just did a podcast with Sanjay Devarsharan on bronchiectasis. So we have a whole podcast on that if anybody really is interested in learning more. That's great. What a great message.
Yes.
Well, so we've gone anywhere from your pulmonary fibrosis, the Advanced Lung Disease Clinic. We've talked about more rare diseases of the lung, more rare than pulmonary fibrosis. We've talked about the whole spectrum of care, patient-centered care. I think we've kind of covered it all, but I just wanted to make sure I give you one last chance to talk about or discuss anything that you think I might have left out. I know I've sent you some of my dearest friends to care for. You've recently cared for one of my friends whose mother was unfortunately diagnosed with pulmonary fibrosis, and I really appreciate the patient-centered care that you give. So I've benefited from your clinic already.
Thank you. I guess just closing remarks. I was motivated to study pulmonary fibrosis as I cared for a patient. And every day that I have an opportunity to see patients, I get that opportunity to be motivated. And so I think a lot of the discovery that occurs in our program, that occurs regionally in the U.S. and around the world, comes from that interaction with patients and the advancement in technologies and knowledge that we're all providing together. I think this is one of the most fascinating aspects of medicine, is that you really can't do this on your own. You have to do it as a community, and I think this is why structures like the Advanced Lung Disease Program and the Lung Institute benefit patients frequently, because it is the collaboration and it is the interaction that ultimately leads to the ability to care better for patients.
Yeah, it's all about that longitudinal patient care. It's really at the center of everything we do. Well, thank you again.
Thank you, Shanda. This was a great opportunity to catch up, and I look forward to participating in another podcast in the future. Yeah,
I love doing this. I always learn so much every time. So thank you again for joining us with the Baylor College of Medicine Lung Institute On Air podcast. Have a great day.